Hello, good evening. Welcome to My Avi Fences and the European Fertility Society. We are back with one more topic and we are back with one more webinar and new expert with us. Dr. Viktoria Mokhnii is with us. Hello, Dr. Victoria. Welcome back to My Avi Fences webinar platform. Hope you are all good and are ready to educate us a little bit more again. It's lovely to have you. Hope you had a good day and are ready to explain what PCOS is and how to manage it. How are you?
I'm okay. PCOS is very difficult topics. We know gynecologists, reproductologists know this. So we continue to development the new treatments, new approach, and hopefully the women with PCOS will be more happier in the future with 100% treatment protocols and successful reproductive issue, metabolic issue. So hopefully it will be 100% in the future.
I'm sure it's going to be an interesting session already, and I'm sure it's going to be interesting topic to discuss. And I'm glad that we are talking about this. So thank you so much, Dr. Victoria, for joining us today as well. And also let me mention that Dr. Victoria is here to educate you, but also here to answer your questions. So we will start with her presentation on PCOS management, but afterwards, as always, there will be time for questions. All you need to do is type those questions in the chat. Dr. Victoria will definitely take care of those for you right after the presentation. So don't hesitate. All is anonymous. We are here for you. So if you wish to ask anything, Dr. Victoria will surely answer those questions for you. And of course, remember it's being recorded. If you cannot stay here for the whole webinar, we will have a recording, so you will be able to watch this. It will be available tomorrow. And now I think we can go ahead with our webinar and our topic. Dr. Victoria, ready to start your presentation on PCOS?
Thank you. Thank you. Hopefully
Brilliant.
we
Thank you so
all
much.
have good evening. PCOS management and successful treatment protocols. Polycystic ovary syndrome, PCOS, is a polygenic and multifactorial endocrine and metabolic syndromic disorder with lifelong complication related to female infertility and social imbalance. PCOS characterized by chronic anovulation, menstrual cycle irregularity, infertility, obesity, insulin resistance, polycystic ovaries, hyperandrogeneous, ovarian dysfunction, hormonal abnormality, depression, impaired mitochondrial health. The pathophysiology responsible for PCOS is multifactorial and heterogeneous. It's a vicious cycle of complex disorder with hyperandrogeneous and predisposition as a predisposition factor in insulin resistance, triggering the development of this syndrome. Genetic, neuroendocrine, metabolic causes lead to PCOS transgeneration components with a five-fold higher risk for daughters born to mothers with PCOS. The high level of AMH at late pregnancy blamed for PCOS in children with high LH pulsatility and higher androgen level. A recent study proposed that this biosis of gut microbiota is potential pathogenic factor in the development of PCOS. And internal mechanism of PCOS pathogenesis, insulin resistance, very important. Androgenism, very important. Inflammation, oxidative stress, obesity, very important. External risk factors, gene promoter, hypomethylation, endocrine disrupting chemicals, physical and emotional stress, nutrient levels. And PCOS linked to anovulation and infertility, we all know this, irregular menstruation, 100%, hypomenorrhea, obesity, mostly women obese, hirsutism, acne, oily skin, chronic low inflammation, immunological dysregulation, insulin resistance, metabolic syndrome, hyperandrogenism, hormone imbalance, low FSH and high LH almost in all women, high AMH, It's very good predictor for the and help us with the diagnosis of PCOS, impaired mitochondrial health, menstrual and pelvic pain, polycystic ovaries, darkening of the skin, not often but sometimes happen, acanthosis nigricans, androgenic alopecia, bowel issue, irritable bowel syndrome like symptoms, type 2 diabetes, cardiovascular disease, depression and mood disorders, non-alcoholic fatty liver disease, obstructive sleep apnea, endometrial cancer. That's all the characteristic of the PCOS. And most successful, we have this four type of classification for PCOS syndrome. So classical PCOS, symptomatic hyperandrogenism, ovarian dysfunction, high level of metabolic dysfunction in polycystic ovaries. Type B, classic PCOS as well, symptomatic hyperandrogenism, ovarian dysfunction, high level of metabolic dysfunction, normal ovarian morphology. We all know the ultrasound ovarian morphology is very important in diagnostic of PCOS. Type C, non-classic ovulatory PCOS, symptomatic hyperandrogenism, regular periods, regular menstruation, moderate level of metabolic dysfunction, and polycystic ovaries. Type D, non-classic, hyperandrogenic PCOS, normal androgens, ovarian dysfunction, little level of metabolic dysfunction, and polycystic ovaries. This is for types, is helping us with diagnostic and improve the successful treatment for these women. Many studies, lately study, have shown a strong association between PCOS and chronic low-grade inflammation in the ovarian tissue and through the body, which additionally stimulated by hyperinsulinemia and obesity and the marker of the chronic inflammation, which we can do it very successfully and detect the help us with diagnosis with PCOS. It's C-reactive protein, CRP, interleukin 18, tumor necrosis factor alpha, interleukin C6, white blood cells, complement element, markers of endothelial dysfunction, high homocysteine. We always doing this marker and rely on this homocysteine result by one and vascular endothelial growth factor, a very important factor too in diagnosis PCOS, and IMH, anti-Mullerian hormone, helping us with diagnostic of this syndrome, is ideal biomarker for the assessment of ovarian reserve and had a good diagnostic value for diagnosis of PCOS. IMH is released by granulocyte cells and T cells in the primordial follicles. Higher expression of IMH is observed in preantral and small antral follicles with 2-4 millimeters diameter up to 8 millimeters. IMH level reflects functional ovarian reserve. IMH level is 2-4-fold higher in women with PCOS than in healthy women. And if women have normal IMH, normal like 2-3, so she cannot diagnosed with PCOS. Hypothalamus pituitary ovary axis imbalance plays a vital role in PCOS development. Increased gonadotropin releasing hormones pulse frequency promote LH synthesis over FSH synthesis. LH promotes the synthesis of androgen in ovarian T cells and arrested follicle development, impairs estrogen and FSH synthesis. Androgens and IMH stimulate gonadotropin hormones neurons and play important role in neuroendocrine dysfunction of PCOS, insulin and leptin resistance, very important factors too, helping us with metabolic disorders. And obesity in PCOS patient regulate gonadotropin-releasing neurons activity and reproductive function. Hyperinsulinemia and insulin resistance play a fundamental role in the pathogenesis of PCOS and associated with chronic inflammation, hormonal changes, follicular dysplasia, endometrial receptivity changes, abortion or infertility. Ghrelin levels, insulin resistance marker, we're using this often too, are lower in PCOS and correlated inversely with hyperandrogenism, insulin resistance. Increasing evidence has indicated a link between the gut microbiotas and PCOS. In the pathological process of PCOS involved the dysbiosis of gut microbiota, endotoxemia, biotransformation of bile acids, synthesis of amino acids in regulating insulin resistance. Short-chain fatty acids. The gut microbiota affected significantly inflammation level, insulin signaling, glucose metabolism, lipid metabolism, hormonal secretion. Dysbiosis of the gut microbiota can destroy the host microbial balance, leading to occurrence of PCOS and type 2 diabetes mellitus. At the genus level, identified as risk factors for PCOS: actinomyces, streptococcus, ruminococcal. And obesity is very important in the PCOS treatment protocol, has a significant impact of female fertility and primary due to increased time to pregnancy, ovulatory dysfunction associated with hyperinsulinemia and insulin resistance, increased ovarian androgen production, adipose tissue responsible for the aromatization of androgen to estrogen, and negative feedback on hypothalamus, pituitary ovary axis, and gonadotropin production, glucose intolerance, insulin resistance, dyslipidemia, hypertension, negative impact on oocyte and embryo quality. Obese patient is less happy and more difficult to treat. PCOS as well, very important, affect quality of life of this patient. Mental health, women's identity, depressive symptoms are more common in PCOS women with abnormal BMI than proper BMI. Depression and anxiety and low self-esteem in PCOS. Physical symptoms like acne, hirsutism, obesity, androgenic alopecia, infertility, amenorrhea linked to psychiatric morbidities. Inflammatory relationship between depression and PCOS. Inflammatory markers in PCOS cross the blood-brain barrier, leading to development of depression. So it's blaming to the inflammatory reaction in whole body. Impaired level of cortisol, androgen, vitamin D, neurotransmitters, and monoamide oxidase, and insulin, insulin growth factor 1, insulin growth factor 1. PCOS characterized by hormonal imbalance and ovarian dysfunction. The guidelines focus on three categories: reproductive, metabolic, and physiological. Reproductive categories include hyperandrogenism, irregular menses, subfertility, pregnancy complication. Metabolic category includes insulin resistance, hyperinsulinemia, obesity, dyslipidemia, impaired glucose tolerance, type 2 diabetes mellitus, hypertension, cardiovascular disease, risk factors. The psychological category includes anxiety, depression, eating disorders, low self-esteem, psychosexual dysfunction, poor quality of life. And about treatment protocol, this is the most successful for the women with PCOS, and PCOS has no definitive cure. It's a lifelong disorder and must be treated individually, and mostly the treatment is symptom-oriented therapy. Very important. Number one is the weight management is a primary, lifestyle modification, low-carb diet, aerobic exercise, and resistance training. If women are losing weight, it's improve insulin resistance, menstrual regularity, everything is improving 50% in the body. Reduction in body weight improves hyperandrogenism, reproductive function, hyperlipidemia, hypertension, insulin sensitivity. Nutritional supplements, vitamins, and minerals to treat PCOS contribute to etiology and occurrence. Vitamin A, very important, B group, E, calcium, chromium, magnesium, selenium, selenium regulation, thyroid function, strengthening fertility, antioxidant and anti-inflammatory effect, regulate carbohydrate metabolism. 8 weeks of selenium, the daily dosage 200 mcg supplementation, reduce serum insulin, triglycerides, metformin, and glucagon-like factor peptide. Liraglutide 3 milligram once daily in the case of resistance to lifestyle modification. Glucagon-like peptide enhance glucose-stimulated insulin secretion and suppresses appetite and gastric motility. Improve insulin sensitivity indirectly. Weight loss, reduction in liver fat, visceral adipose tissue, triglyceride, total cholesterol, improve ovulation and menstrual cyclicity. Metformin improving insulin resistance, decreasing total testosterone, trigger ovulation, enhance menstrual cyclicity, improve dyslipidemia. Probiotic micro, we're using probiotic now all the time. It's probiotic microorganisms have antioxygenic, antimicrobial, anti-inflammatory properties, regulate the immune system, improve metabolic profiles, reduce weight, lower glucose and insulin level. Probiotics have positive effect on metabolic and immunomodulatory markers, reduces hyperandrogenism. Only successful treatment based on gut microbiota, probiotic, prebiotic, symbiotic. And myoinositol, very successful too. Myoinositol combined with D-inositol has some should be rate myoinositol more than D-inositol and alpha-lactalbumin, improving insulin resistance, lipid metabolism, and decreasing total testosterone, menstrual recovery, regulate TSH, thyroid stimulating hormones, FSH, decreased LH, prolactin, androstenedione, insulin. Folate and vitamin B12 reduce the homocysteine level and potentially improve metabolic profiles. Degree of vitamin D deficiency correlate with the severity of PCOS, decreases serum androgen and AMH level, inhibits tumor necrosis factor alpha, increased production of ACG, anti-inflammatory activity, improving insulin sensitivity, decreases triglycerides, improve glucose level, hyperlipidemia, free androgen index. Oral contraceptives, estradiol has a direct anorexigenic effect and reduce food intake and increased energy expenditure. Estradiol and glucagon-like peptide proposed as a novel therapeutic approach to restore healthy body weight and prevent the development of the neurodegenerative disorders. Anti-androgen flutamide protocol for menstrual abnormalities, negative feedback on LH secretion and reduction of androgen production in the ovaries. Low androgen is very important for the endometrium quality and successful implantation, inhibiting the peripheral conversion of testosterone into dehydrotestosterone. Dehydrotestosterone reduce hirsutism and acne, improve metabolic characteristic. And I wanna share two cases. Patient number one, 25 years old, 82 kilogram, irregular menstruation since 15 years old, no ovulation detected on transvaginal ultrasound, ovaries volume 13 and 15, increase. Normal volume is less, around 10. Sonographic PCOS endometrium, oral contraceptives menstrual cycle, IMH 11, thyroid test normal range, prolactin 8 normal, homocysteine 10 normal, basal estradiol 20, it's a little bit less. Dihydrotestosterone elevated, 625. Free androgen index elevated, 9.2. Leptin is 22 nanogram milligram. Low density lipoproteins elevated. Cholesterol and triglyceride elevated. Hysteroscopy detected signs of chronic endometritis. I will show you the hysteroscopy video, and I will try to show you this endometrium. So this is, you can see the sign of chronic endometritis, spots and red endometrium. It's not normal. It's showing the inflammation, red spots, increase blood vessel, and this endometrium mostly will not get pregnant. And I will get back to the treatment protocol. Treatment protocol. Treatment protocol, anti-inflammatory treatment to uterine cavity, depend of the microbiota, anti-androgen to decrease level of dihydrotestosterone and endometrium receptivity, gonadoreleasing antagonist protocol, IVF ICSI with gonadoreleasing agonist triggering. We got 5 good quality blastocysts, freeze all approach almost always in PCOS protocol, embryo transfer in replacement, hormonal replacement therapy cryocycle, low carb diet and exercise. She lost 5 kilogram in 2 months. My inositol is very important to low insulin resistance, 2 milligram daily, vitamin D, 5,000 international units daily, daily probiotic, folate, 400 mcg daily, selenium, 200 mcg daily, coenzyme for restoring the energy, mostly 200 milligram daily, and we got successful pregnancy in 4 months. And I want to tell you about relationship of the chronic endometritis and in PCOS endometrium. It's very important. Insulin inhibits insulin resistance. Insulin inhibits the insulin growth factor binding protein, and this is factor insulin binding protein is a biomarker of desidualization of the endometrium. Hyperinsulinemia affect the normal function of the endometrium, leading to fillet embryo implantation. Insulin resistance trigger endometrium inflammation almost always and lead to progesterone resistance. Endometrial stromal fibroblasts in PCOS have an aberrant desidualization response to progesterone, and this is the cause of endometrium dysfunction. Insulin resistance increases the sensitivity to local estrogen in endometrium and promotes endometrial hyperplasia. Insulin resistance occurs when the effect of insulin on cells is lower than normal, resulting in decreasing glucose utilization, increased liver gluconeogenesis, increased blood glucose, and compensatory hyperinsulinemia. Hyperinsulinemia is very detrimental for the quality of endometrium. Insulin resistance related to obesity, low-grade inflammation, leptin resistance. Hyperinsulinemia increases the bioavailability of androgen. High level of androgens and insulin in the plasma affect the periodic exfoliation of the endometrium. Endometrium is a highly dynamic tissue and periodically shed in response to the secretion of estrogen and progesterone. Multiple factors, anovulation, endocrine metabolic abnormalities, inflammation disrupt the endometrium in PCOS patient. And, PCOS patient. Patient number 2, she's a young woman, 23 years old, 67 kilogram, irregular menstruation since 16 years old, no ovulation detected on transvaginal ultrasound, ovaries volume 12-13, sonographic PCOS endometrium, sonographic PCOS endometrium. It's has a look like inflamed endometrium, not clear. The line between endometrium and myometrium not very clear. We don't see the middle line very clear. So we can detect this PCOS endometrium like more tissue, not very healthy tissue, and sonographic PCOS endometrium and polyp of the uterine cavity. Oral contraceptives menstrual cycle, IMH9, is elevated, can predict of PCOS disease. Homocysteine 12, a little elevated, thyroid test normal, prolactin 9, basal estradiol 30, the hydrotestosterone 325, it's normal. Free testosterone elevated, hysteroscopy diagnosis, chronic endometritis, polyp of the uterine cavity. So here is the hysteroscopy of this patient. We see the chronic inflammation too. Increase the vascularization of endometrium, red spots, showing us the inflammation and polyp. The patient was done hysteroresectoscopy of this polyp, the treatment of the uterine cavity with the antibiotics and vitamins, insulin sensitizing medication. Protocol, hysteroresectoscopy of the uterine cavity polyp and anti-inflammatory treatment of the uterine cavity, anti-androgen treatment for good quality endometrium and hormonal balance, because we never had successful implantation if androgens elevated. Endometrium has androgen receptors, and then endometrium not able to have normal implantation of good quality embryos. Vitamin D3 5,000 international units daily, selenium 200 mcg daily, myoinositol for insulin resistance 2,000 international units daily, 2,000 milligram daily, sorry. Vitamin E 400 milligram daily, probiotics daily, very important for the intestine health. Folate 400 mcg daily, coenzyme for the mitochondrial health 200 milligram daily, magnesium 200 milligram daily, magnesium increasing insulin resistance too, and lowering the glucose in the blood, optimizing sleep, emotional well-being, gonadoreleasing antagonist protocol, like always in vitro fertilization XC protocol with gonadoreleasing agonist triggering, 3 good quality blastocyst, freeze all approach, embryo transfer in hormonal replacement therapy, cryo cycles, successful pregnancy in 5 months. In 5 months, and we're using vitamin E. Vitamin E as well improves insulin sensitivity, and now we start to use niacin. Niacin antiphospholipid medication improves peripheral blood supply. Niacin also increased the number of normal antral follicles, reducing the number of cystic follicles, and increased serum adiponectin concentration, and it's very good for the treatment of the PCOS in the PCOS protocols. So, woman, and conclusion for the PCOS treatment management of this disease. Women with PCOS often and identified in adolescence with symptoms of oligomenorrhea or hirsutism or infertility care. The health risk associated with PCOS extend the reproductive years through and beyond menopause. Most patients are dissatisfied with long-term counseling related to medical and physiological issue. PCOS is mysterious and complicated endocrine disease with the combination of metabolic, reproductive, psychological dysfunction. More research is required to understand optimal self-management strategies, risk perception, energy homeostasis, overcoming nutrition in women with PCOS, and early and precise diagnosis is important for an adequate management of PCOS. PCOS women are unhappy women. They want to be beautiful. They want to have normal weight. They want to have regular menstruation and desire to have a successful pregnancy, whatever they want. So this is very important to listen to them, to understand them, and to go with the direction what they want to be on the stage of the life if they want to be pregnant. So take care of everything, because the PCOS, it's not just a reproductive problem, it's a all body problem. So to have to uh, correlate with metabolic problems and uh, uh, um, to have a reproductive issue and have a successful pregnancy in this woman, and woman, especially young women who want to be just healthy and don't want to get pregnant in this moment. So make them to have regular menstruation, because it's very important for the healthy of the PCOS endometrium, if I can to say like this, because the endometrium should shed every month approximately for the future health and the future um, successful pregnancy, successful implantation. If the endometrium stay in the uterus for the 5 months or 6 months, then in the future you might have problem with the successful implantation. And of course, the stimulation of the good quality follicles and ovulation, it's no, not easy, but more easy than in the future have a good quality endometrium. So PCOS endometrium is very important, and to keep this endometrium healthy is very important. And I wish all doctors, reproductologists and gynecologists good luck with this treatment. Not underdiagnose and correctly diagnose on time this issue, this disease, and make the women healthy and happy with our treatment protocols. Thank you so much.
Brilliant. Thank you so much, Dr. Mokhnii, for presenting this topic and for your thorough explanation and providing the actual, the cases, because this is always interesting part, I know. So thank you so much for giving this opportunity to give us real examples as well. And now, if you have any questions, you know what to do. You can type the questions in the chat, and there are 2 questions already. However, if you have more, you know what to do.
Yes.
We're here for you. And let's.
Return to, and I don't know
Yes, of course, I will show you the questions right here, so don't worry. I think you can see it, I hope, right now.
No, I don't.
You can stop sharing your screen and it should be all okay.
Okay.
And I will show you the first question. Can you see it now?
No. I'm sorry for this.
It's okay. So the question is, have you ever heard that PCOS can be quite often overdiagnosed? This is the first question.
Yes. Overdiagnose. Can you give me more specific about overdiagnose? Yes, overdiagnose, underdiagnose all the time, because the PCOS has not only not regular menstruation, but more metabolic issue. And but if the women girls come into doctors and complain about not regular menstruation, do not have menstruation for 2-3 months, then of course we're looking for the for all signs. It's ultrasound signs of the PCOS, polycystic ovary syndrome, androgen. It's very important, hyperinsulinemia, metabolic disorders. And on the first place, it's a hyperandrogenic, not regular menstruation. polycystic look on the um, ultrasound signs. But for one time when women come to doctors, we cannot diagnose, mostly we cannot diagnose the PCOS, and we try to have more appointments with women and look for more answers and diagnose more precisely the PCOS, and mostly always okay.
And thank you. Thank you so much for your first question, Lisa. And Lisa actually has another question here. So the question is, so what is the prognosis for PCOS patient with own eggs IVF outcome? I'm 36 already. I'm worried more and more.
Elisa, I would like to come back to this question, and I don't know how.
And have you been able
Have you been
to,
able
you cannot see, can you see me in such case?
to?
And
No, I don't see.
can you take a look at your sorry, you have probably some other windows opened. Can you have a
Okay,
look
so
and see if possible?
I will try to
Hmm.
concentrate
I
on the
can
question.
I
Okay,
can
so
repeat it if you
another
need.
question is 36 years old. Yes,
Yes.
36 years old, and she asked me about um,
IVF outcome with Onyx.
IVF outcomes. And what is your IMH? Can you tell me? Antimullary hormone.
Lisa,
IMH,
if you can
antimullary
give us some
hormones.
more details, of course, please write it down.
And what is your body weight?
I don't see the answer yet, at least. Okay, so let's give it a
Okay,
minute.
and okay, so 36 years old, and we're going
Mhm.
to the 40. And very important, if she had children or not, what is her body weight, and if she got pregnant before. For her prognostic is like I need a more specific. So we can manage everything, and she can get pregnant successfully. We have overweight women. We have with elevated prolactin, impaired thyroid health, with not regular menstruation, with elevated AMH. I have two girls who has very high AMH, 32 and 27. It was very high and was very uh, dangerous to go to stimulate these women, but we managed. We got good quality embryos and successful pregnancy um, for one and for another one. So we can work with PCOS very successfully in the IVF protocols if she like to get pregnant, because mostly we cannot manage in the natural protocol successful pregnancy with PCOS. Only mostly successful pregnancy in IVF IVF cycle. So we can manage this and always does.
Okay, thank you so much indeed. I don't see more details from Lisa, but of course, if you wish to give us some more details, go ahead, type this in. Someone is typing, so we need to give it a minute for another question. But thank you so much already, Lisa, for sharing and for your questions. We need to wait a minute to get the other question, I believe, as someone is typing. And in the meantime, Dr. Mokhnii, if you can try and see if it's possible for you to see, so it's easier, of course, for you. Not
Yes,
sure if you can find the window right now.
I don't, but it's okay. I
It's
will
okay.
listen
I
to
will
you.
read the questions for you then. So it's all okay. We just need to wait a minute as we are waiting for some more questions. And again, I see
Mhm.
someone is typing. Not sure.
Very
So
important in the treatment protocol is very important IMH of the women, because IMH give us successful protocol. management and adding some medication to improve the quality of eggs and the quality of embryos. Then we need a have a good quality endometrium, and this is like not fast too. So mostly, first of all, we need to have good quality embryos. Then we prepare the endometrium with anti-inflammatory treatment, with the um, podium development, the best time, and transfer the embryos. And almost always we can manage successful pregnancy in these women. So you don't have to scare, but if you will
Mm-hmm.
wait by 40, it will be less successful protocol. If you
Of
can't,
course.
please don't wait, because the age cannot be managed uh, by now. So the age is very important to get good quality
Mm-hmm.
eggs and quality embryos.
So in case of in this case, if you are 36, it's better not to wait anymore and just start
Yes,
treatment as soon as
36.
possible.
I'm positive if she have a like PCOS, she probably knows this, because she told me, she said she have PCOS,
Mm-hmm.
diagnosed with PCOS, so probably high IMH level, and the less if not because polycystic ovary syndrome indicate not all follicles can grow and got the good quality eggs. Sometimes this is follicles empty. Sometimes we got bad quality eggs, but mostly always 2, 3 good quality embryos in the end, and we can get successful pregnancy. But
Okay.
PCOS managed not very easily. It's depending on blood test results, of her weight, of everything, hormonal screening. So it's very important to know more details. But mostly,
Right.
yes, I'm positive. Um, Many clinics can manage successful protocols for PCOS, because by now we have antagonist short protocols who
Mm-hmm.
can give us opportunity to get to preserve the hyperstimulation syndromes in when we stimulate PCOS women, and
Okay.
get good quality eggs, and in the end get good quality embryos and quality and successful pregnancy. And endometrium is very important in this woman too.
Okay. Thank you so much indeed for your additional, of course, answering additional questions here as
Yes,
well.
but it's
Mhm.
not easy. So it's not easy. I
Mm.
agree. And these women, unhappy with IB. With weight, if
Mm.
people has obesity, so they just come in and asking for the losing
Mhm.
weight. Most successful protocol for losing weight, then if she losing like 10 kilograms, 5 10 kilograms, her menstrual cycle start restoring, and she got more regularity with menstruation, and sometimes can be the ovulation, and they can get pregnant without protocol, without stimulation.
Okay, brilliant. Thank you so much indeed for that. There are two more questions. So let's have a look at the next one from another patient. So you mentioned that using inositol, sorry, in
Yes,
PCOS, but there is a big debate, and Cochrane publication tells that
yes.
there is not a good evidence of benefit of this myoinositol. What do you think?
It's not about myoinositol. Myoinositol is very good. It's about chiroinositol, and chiroinositol increase the androgen level. Yes, it's a big debate, but myoinositol to chiroinositol should be in the relationship 4 to 1, myochiroinositol in some study 40 to 1. But myoinositol always improve insulin resistance, FSH stimulated, and mostly good for the management of the metabolic syndrome in PCOS patients. Yes, this is the study, but about metformin too. but we're using metformin very successfully, and glucagon like peptide factors is starting now to be more successful, and women with PCOS has a low estradiol level, and adding the estradiol improve the metabolism too and improve the very quick. In some women with PCOS, they start losing weight very quickly. But I agree about myoinositol. It's in ketoinositol. It should be relation 4 to 1. Myo 4 times higher than ketoinositol. But it's very good drug too. We're using myoinositol very successfully. So it's of course it's a patient dependent. If the patient not like satisfied with this drug
Mm-hmm.
and don't see improvement of the weight losing on metabolic disbalance, so we can have the more successful treatment, but mostly myoinositol very successful.
Sure. Okay. Thank you so much indeed for your
we have
question.
we have many women on myoinositol, and I can
Mm-hmm.
say they successful, so
Right.
it's just
Okay. Great.
Yes, but we going to get more development in the PCOS treatment, and
Yes.
most important is the uh, lifestyle and weight management. So this is the number one and most important. If you lose the weight, you can improve the menstrual cycle and ovarian function, and even the ovulation without any stimulation. Yeah, I'm
Brilliant.
sorry
Thank
if
you
I.
so much. And now we will go to the question, another question with some details. More
Mhm.
possibly our final question. So if you have more, you know what to do. And the question is here. So I have had PCOS since age 15. I had 5 IVF transfers, 3 using
Mhm.
donor eggs. I take magnesium, probiotics, vitamins D and E, myoinositol supplements. I've had a hysteroscopy done, was found not to have endometriosis. I've also lost over 55 pounds, yet I'm still having implantation failure. What can I add to my protocol to give me a better chance of pregnancy? I'm 44, been trying to get pregnant for over for 4 years. Sorry.
And what is the weight? I'm sorry because I didn't see the question.
There's no
Weight.
information
She
about
lost.
weight,
She lost
but
the patient. She lost 55 pounds.
yes,
And
55 pounds. Yeah, over 50.
hysteroscopy. Hysteroscopy is not about
Mhm.
endometriosis. It's about endometritis, inflammation, low-grade inflammation in the uterine cavity, because insulin resistance always always give the low-grade inflammation in the uterine cavity. Almost all patients with PCOS, in the hysteroscopy, we can see the inflammation, more or less, but inflammation. And if you mean in endometritis, no endometritis. So it's different. Endometriosis is different than endometritis and has mostly no relation to PCOS. And how you can improve, how you can get pregnant. You 44, so if you never be pregnant before, you better use eggs. In what is your IMH2? It's very important, anticolon hormones. So we need to have good quality blastocyst, good quality embryos, and then uh, find your window of implantation. Your thyroid should work properly, probably prolactin too, and you should get pregnant. If you lose the weight, lose the weight. So improve its metabolic disorders in the body. And sometimes doctors say it's no inflammation in the uterus. They don't see that, but it is. So if you want, if you would like, I can look through everything and can help you uh, all piece. So you should get pregnant if you have uterus, if you have treated the endometritis, and if you have good quality embryos and window of implantation era test with the precisely knowing the time when to transfer the embryo, and then you will get pregnant. If you have no endometritis in the uterus, please send me the photo of this. And about era test, if you answer to Caroline about the ERA test, if you done this test, because it's very important too. It's not about PCOS management, because I understand you manage this well. You lost the 55 pounds, and you take all kinds of vitamins and myoinositol and everything. So you have to have good quality embryos, ERA test, and healthy uterine cavity, and then you will be successful. I'm positive.
Okay. Thank you so much. If there are any follow-ups, of course, you can type this now. But if not, remember, you can always get in touch with Dr. Viktoria and her team at Ekstramed, and I'm sure they will be happy to help you out with any questions you might have. And of course, I know that Dr. Viktoria always needs more details to give you a proper answer. So remember that AMH, age, all this matters. So if you wish to have some more details, just send this to the team at Extramed. I'm sure they will be happy to help you. As I mentioned, it looks that that was our final question, but thank you everyone for joining. Do believe it was useful. I'm glad that we are
Oh,
talking
finally,
about
I finally
PCOS.
can see myself. My God, because I'm losing. I'm just looking and
But we
I have
managed even without it, so I'm glad everything is working, so all is okay. And thank you so much, Dr. Victoria, for joining us today. Any final words before we finish?
from me. Yes,
Yes, of
final
course.
words from me. If you have PCOS, please don't worry. We have so many successful treatments, successful protocol to everything what you like, to be healthy, to be beautiful, to have successful future, successful work, and regular menstruation, and have successful implantation and successful pregnancy. So please find your doctor, find your clinic, and manage successfully PCOS. PCOS disease. So it's not the like final something what you have to suffer
There are
and
ways to treat it.
suffer.
Yes,
Yes,
and it's
it has.
possible.
We have so many way to treat and give you. Um, give you a beautiful and successful life with everything, with regular menstruation, with successful pregnancy, with regular menstrual cycle, and no depression and absent of depressions.
Brilliant. Thank you so much for that. And of course, we will be finishing for today. But as I mentioned, you can always get in touch. There will be more webinars coming up. So stay tuned. And thank you so much for joining. We will be back for sure. And Dr. Victoria, again, it was lovely to have you. Thank you so much for today. And of course, I'm really looking forward to some more webinars coming up with you as well. Thank you. Take care. Have a lovely evening, everyone. And hope to see you soon as well. Take care. Bye.
Thank you so much. Thank you. Bye bye. Thank you. Thank